We move on next to the WCCPCI 2012 Sushil Ansal oration. This year it's being conferred on Professor N. Khanna from Delhi on the topic peripheral vascular interventions. He'll have 15 minutes for the oration and 3 minutes for the oration conferring. I would hand over the proceedings to Dr. H.K. Chopra from this moment
ladies and gentlemen, I'll request Dr. Pancholia, please join me here on the dais. A.K. Pancholia. Dr. Rao, Muralidhar Rao, please come on the dais. So ladies and gentlemen, it's a very, very prestigious oration, which is in the name of Sushil Ansal. He is a tycoon in the real estate in the world. And he has recently established Ansal Hope Institute of Healthcare in Lucknow, which is the very biggest institute in collaboration with Virginia and with Poland. And he is the chairman of the institute, and I am the vice chairman of this institute. And we are going to work very hard to have some kind of a twin sharing education in the medical care. And I am really very fortunate that we have a guy who is from Lucknow, N. Khanna, who is trained and educated in Lucknow, and now he is the chief of vascular intervention in Apollo Hospital, a very academician par excellence, and a very humble person, very soft-spoken, and a great organizer who has been organizing a lot of meetings on this. I am very fortunate to bestow upon this oration on him, and I request all the chairpersons to please join me to bestow upon him the medallion and the scroll before he really delivers the oration.
Thank you, Dr. Chopra, for inviting me and for those kind words. Members of the august audience, I'm going to speak today on peripheral vascular interventions. I'm an interventional cardiologist, and peripheral vascular intervention is my second love, and how an interventional cardiologist of today is transforming to treat peripheral vascular disease and to conquer vascular disease in the entire body. So I'm just going to take you through what we do and just to give you a brief idea of this. I have this is a Sushil Ansal oration. I have a very high regard for Mr. Ansal. I hope he was here, but in his honor we are going to address this. As we see manifest coronary artery disease, 40% of these patients would have carotid disease, renal disease or peripheral vascular disease. And to treat this as an interventional cardiologist, because the etiology is same, either they are stenotic lesions or thrombotic lesions or aneurysmal lesions, we have to put in the skills of a vascular surgeon, interventional radiologist and an interventional cardiologist and transform ourselves into vascular interventionalists, and that is how we can treat these diseases. Now, the cath labs of today have actually changed to hybrid ORs or vascular interventional cath labs, which have the setups of operation theater, which have perfusion machines, which have bedside echoes, and many more things, and a 12 to 18 inch, 15 inch IE. This is how we do. We don't not only get patients from cardiology and cardiothoracic surgeons and vascular surgeons, we get referrals from nephrologists, urologists, transplant surgeons, pulmonologists, gynecologists, and a wide array of specialties. This is a post-transplant patient who had a transplant rejection because of the anastomotic stenosis. We can treat them easily by a stent deployment at the anastomosis. This is another patient post-renal transplant who had hematuria following renal biopsy, and this patient was undergoing nephrectomy, possible nephrectomy. We could embolize this patient and arrest the bleeding. Now, patients with hypernephroma can be embolized, the vascularity can be reduced, and these patients can have a very easy surgery, a bloodless surgery following that. Patient with bilateral renal artery stenosis can easily be treated in one sitting in half an hour, and blood pressure and renal failure can be controlled. This is my series of about 1174 patients with 1184 stents. Most of these lesions are osteal. There are very few non-osteal lesions in fibromuscular dysplasia, and in one of these patients we had treated a bypass graft with a stent deployment. The procedural success in renal stenting as of today is 100%, and there is a definite reduction in the degree of stenosis. There is a very high improvement rate in the control of hypertension, and in about 10% of the patients the hypertension is actually cured. In patients with borderline renal functions, that means a creatinine of around 1.5 to 2, these patients with renal artery stenosis usually do very well after renal artery stenting, and we can always prevent the progression of renal failure in these patients. Patients who present with pulmonary edema, most of these patients actually do very well. Now, coming on to other domain, the surgeon's domain, where acute limb ischemia, critical limb ischemia were considered to be a vascular surgeon's domain, and it's no longer true. At least in my hospital, the vascular surgeons never get these referrals. Now, this is a patient of superior femoral artery thrombosis presented with acute limb ischemia and ice cold limb, and we could treat these patients very easily with indwelling catheter with the ongoing tissue plasminogen activator therapy. Now, patients who have complete chronic long total occlusions of superficial femoral artery or below knee arteries, we can actually do a subintimal angioplasty and put in stents, and these patients do very well. Now, this is again another patient of a long occlusion, and you can see we have done a successful subintimal angioplasty, and these patients can be treated without a bypass surgery. Popliteal artery stenosis and aneurysms again was thought to be non-territory where stents cannot be deployed, and as of today the stents can be easily done here. We can treat infrapopliteal disease and popliteal aneurysms. Lyric syndrome, again one of the major surgeries which the vascular surgeons used to do, no longer falls into their domain. We treat these patients almost exclusively by an aortic stent followed with a pre-stenting thrombolysis. Aortic aneurysms are treated very simply by endovascular graft. Most of the aortic aneurysms can be treated with endovascular grafts. Uterine artery fibroids in fertile women, we get a lot of referrals from our gynecological colleagues. We can do a PVA or a coil embolization of uterine artery and treat these patients and still maintain their fertility. Coming on to the venous sites, we treat deep vein thrombosis by indwelling catheter and thrombolysis, or we can also do a thrombectomy either from the deep vein, IVC, or also from the pulmonary arteries. We put filters into the pulmonary arteries which could be permanent or retrievable and treat a large variety of venous diseases. This is a patient where we have done TIPS. This is for patients with non-viral cirrhosis leading to portal hypertension, and there is no need for a surgical portosystemic shunt. We can actually do it percutaneously. Patients with Budd-Chiari syndrome can actually be treated and are being treated successfully with percutaneous interventions. Patients with IVC thrombus, and also patients with mesenteric artery thrombosis, mesenteric artery aneurysms can be treated with thrombolysis and covered stent grafts. Duodenal bleeds and other GI bleeds can be treated with coil embolization or PVA particle or gel embolization of these arteries. Now, coming on to the pulmonology side, we get a lot of referrals with hemoptysis, especially patients who have bleeding because of bronchial bleeders, and we embolize these patients, and this is a very gratifying procedure. We can actually arrest the bleeding on the table and save many lives. We also treat many AV malformations, AV fistulas of the pulmonary vasculature, and these patients need not go for a lobectomy or pneumonectomy. In acute strokes also, we have ventured into carotid artery stenting, intracranial thrombolysis for acute stroke. This is our result of 388 patients. Most of the patients now we do with cerebral protection, which could be proximal protection by flow reversal using a MOMA device, or a distal protection using a filter or a balloon. And in many of these patients, we combine angioplasty procedures. And this is my follow-up of 283 patients. Only 3 patients had a TIA or stroke. There is no risk of restenosis or stent displacement if we properly choose our patients. So you can see, apart from coronaries, there is a huge array of diseases of vascular system which we can treat with the same techniques, just applied in a different way in different vasculature. Now this is very interesting. And the varicose veins, which is occurring in about 10% of human population, especially in people who have jobs like professions which requires prolonged standing or sitting, and in housewives. And this is treated by in an OPD procedure or a daycare procedure with endovenous laser. And this is what we started in 1999. This is my personal series of about 8,000 patients. And most of these patients undergo, after a good duplex ultrasound, endovenous laser therapy. We use biolytic and diomet systems using 980, 810, 1360 and 200 micron fibers. The results are very gratifying. Only 17 patients had a DVT, none of which was fatal. Pain is the usual complaint, but this pain is quite mild and can be managed with painkillers. Swelling is rare and ecchymosis is present, but it resolves in few days' time. We have done a duplex ultrasound follow-up in about half of our patients. At 6 months and 12 months, the patency rate is about 97 to 94%. This is some of the pre and post results of our and varicose vein treatment by endovenous laser, and this is a very gratifying procedure. The other advancements are we can do most of our cases now of peripheral interventions through radial route. We use FFR to assess the severity of these lesions like in coronaries. We can treat dilated cardiomyopathy by putting in Alfieri stitch or an E-valve percutaneously using a 3D guidance. And also we can replace aortic valves percutaneously under fluoroscopy without any surgical incisions. This is how we do it. We do it under TPI pacing. We keep the heart rate around 180 to 200 and put a balloon expandable stents. Our cath labs have now been integrated with CT machines so that we can have a 3-dimensional reconstruction, and actually we can plan our views and actually put the devices with very high accuracies, which is very important in aortic stent grafts and also in aortic valve implantations. Now, there has been more advancement in endovascular treatment of aortic aneurysms. We can treat these aneurysms across any vasculatures. We don't have to worry about the side branch if we put in covered stents, non-covered stents, which are called as multi-layered stent or multi-layered flow diverters. And with this new technology, we can treat any aneurysm across any vessels. We don't have to worry whether the vessels would be closed or not. Now, resistant hypertension is treated today by renal artery sympathetic denervation, which is very common, and now it's a common way to treat resistant hypertensions all over the world. There's been a lot of debate about the use of internal jugular artery stenting in treating multiple sclerosis, so I'm not going to just go through it. We have treated about 100 patients with good results, but those are very subjective results. In patients with no options, we actually resolved to stem cell implantation. This is our patient of autologous stem cell implantation in critical limb ischemia, and these patients do quite well and we can save many limbs. Now, patients with carotid aneurysms, carotid blowout, which are totally non-surgical candidates, also are treated easily by percutaneous techniques. Now, this is a typical patient which we get. This is a patient with aortic arch aneurysm, right renal artery stenosis, proximal LAD stenosis, and a bilateral aortoiliac stenosis, which we treated. This is the only groin incision which we put. These patients are clearly very high risk for surgery and cannot be treated. This is a cath lab setup, and we treat first the aortoiliac disease by aortoiliac stents. Then we treat the coronaries by putting a LAD stent. We treated the aortic arch by putting in a stent graft, and the renal artery by a renal stent. This is our personal experience, 289 patients, most of which are abdominal, about 100 are thoracic aneurysms. The surgical conversion rate, only in 3 patients out of about 289 were converted for emergency surgery. And 27 patients had endoleak, 9 of which we resolved on the table. We did hybrid procedures in 21 patients and chimney procedures in 7 patients. Now, patients which are not fit for standard aortic stent graft, we do many procedures which can help us to increase the landing zone. We can do ascending aortic stent grafting by doing innominate rerouting of the cerebral vessels. We can do a carotid subclavian, or ascending aortic to branch graft to both the carotids and left subclavian. So we can actually treat the entire aortic arch and thoracic and abdominal aorta by various combination of hybrid procedures. We can also do something similar like Bental in aneurysms of ascending aorta with dissection. We can put a percutaneous valve, which aortic arch graft, and also do covered stent implantation for both the coronaries. So these are the things which are done. These are not theoretical. These are being done in humans, and most of it is also being done in India. The new things which are now being done is we don't need a covered stent. We are putting aortic stent graft and a multi-layered flow modulator in the entire aortic arch. And this we do not require to do hybrid procedures. And what it does not occlude the side branches, but it reduces the stress on the aortic wall, and this leads to a reduction in the risk of rupture over a period of time. We can put this stent across any vasculature, thoracoabdominal aorta or cerebral or aortic arch. Also, in aneurysm, we have identified genes, and if we actually use the science of epigenetics, we are now thinking of turning on and turning off the modulation of these genes so that we can prevent the progression of an aneurysm and prevent rupture of this aneurysm even without putting in any stent grafts or doing surgery. The last thing which I want to discuss, which we have really started now, is erectile dysfunction in males. And these are patients of complex erectile dysfunction who have failed Viagra therapy, and where all other causes have been excluded. A proper duplex scan has been done after intracavernosal injection of pepaverine. Dr. Kapoor helps me a lot in these patients. And once we identify these patients, we actually then do an angiogram, and if we find a block in the pudendal artery and we treat them with medicated stents, most of these stents recover. We are the only center, the second center in the world and the only center in the Asia Pacific region which is doing this erectile dysfunction stenting in male erectile dysfunction. This is a duplex scan, and this is how it's done. We go from the contralateral side, we hook the common iliac from the contralateral side, and after that we engage the internal iliac, then go to the anterior branch of the internal iliac, and then stent the pudendal artery.
Carry on, please. Excuse me. Let him show the last slides.
Can I put last? Okay. So this is, I'll just take half a minute. So we approach the pudendal artery, and after that, once we see the stenosis, we wire it under DSA mapping, and after wiring, we put a stent at the stenotic site, and after putting in a stent, we can actually treat these patients and treat the pudendal artery stenosis. Now, these patients have a follow-up by duplex scan, but the best follow-up is the patient's own response. And till now, we have done about 23 patients. We have used drug-eluting balloon in 11 patients. We have used drug-eluting stents in 12 patients, and we have a clinical success of 21 patients. So you see, from interventional cardiology, we have branched out to vascular interventions. We can treat anything from head to toe. We provide major surgeries. We bring a lot of hope to the patients. We give a lot of relief to the patients and their attendants. But when it comes to billing, that is the biggest killing thing. The patient or their attendants have a second heart attack. So that's where we need to tackle, we need to indigenize things, and hopefully we can treat these patients by using Indian products which could be much cheaper. Thank you.
Thank you very much, ladies and gentlemen. Dr. N. Khanna has really evolved as a giant in the vascular intervention now, and he has really made his own name. And the way he has mentioned, wherever the vessel is, whether it's a venous or arterial, he intervenes. And I think the success rate is enormous, and a lot of referrals are coming to him for the peripheral, especially for carotids, as well as I think the recent work which he is doing with Dr. K.K. Kapoor is on the penile artery stenting, which is something really great, and I think the success rate is very, very enormous. I'll request Dr. Pancholia to make a comment.
Well, in the era of coronary intervention, to do peripheral intervention is a challenging job. And Dr. Khanna, I know, is involved highly in this peripheral intervention, is doing incredible job in this particular field, because there are several areas of peripheral, and most of the patients are benefited with those interventions.
Let's give a big hand to Dr. Khanna for his outstanding presentation. Thank you.
Ladies and gentlemen, we'd like to thank the chairpersons for chairing this leg of the oration.